Welcome to the deep dive. Today we're putting a spotlight on a really powerful part of our endocrine system, the posterior pituitary gland.
hmm
It's this tiny structure, but it holds the key to the body's whole fluid budget. It's quite amazing.
It really is an incredible system, all checks and balances. And today we're going deep into AVP arginine vasopressin, which, most people know as ADH, antidiuretic hormone.
Right, ADH. So our mission today is pretty straightforward. We want to unpack the physiology of ADH, understand how it keeps us balanced normally,
Yeah.
and then look at what happens when it goes wrong. The two really dramatic opposing disorders, diabetes insipidus, DI, and the syndrome of inappropriate ADH secretion, SIADH.
Opposites.
We want to understand what they are, but also how they're diagnosed. And, well, sometimes the treatments are a bit surprising.
They definitely can be. So maybe just to set the stage, ADH, it's actually synthesized higher up in the brain, in the hypothalamus. Specific nuclei there.
Supraoptic and paraventricular.
That's them. Then it travels down to the posterior pituitary, which stores it and releases it.
Okay.
And its main job, simple concept, vital function, maintaining body fluid balance, homeostasis, and plasma osmolality. It does this by controlling how permeable the kidney tubules are to water.
Okay, let's unpack that normal function first, because the sources emphasize that ADH regulation isn't static, right? It's very dynamic.
Absolutely. You have to think about ADH control in terms of body volume in, let's say, normal everyday states, when you're normovolemic.
Meaning normal fluid volume.
Right. Then the hormone release is really finely tuned. It mostly responds to osmolality changes, basically, how concentrated your blood is.
But what if things go sideways, like in an emergency situation?
Well, if you get into an extreme state, like severe hypovolemia, maybe from bleeding, or just profound dehydration,
Okay.
then the volume sensors, the baroreceptors, they actually override those osmolality signals.
They take precedence.
Totally. ADH release just ramps way up. The priority becomes preserving volume at all costs, even if that means osmolality isn't perfect for a bit.
That makes a lot of sense. Survival first. ADH is the body's ultimate water reclaimer then.
It is.
But we should also remember, looking at the bigger picture, ADH isn't working alone to manage volume, is it?
No, that's a really critical point. ADH is a heavy hitter for water directly. But volume control involves a team. You've got the RAS, the renin-angiotensin-aldosterone system.
Right. Dealing more with salt and fluid overall.
Exactly. And other things like pressure natriuresis. It's a coordinated effort.
Okay, that holistic view is key. So with that background, we can frame the problems of pathology. If ADH is this powerful, then when it fails, the consequences must be pretty dramatic. We're basically looking at two extremes. Not enough ADH versus too much ADH.
Precisely. So let's tackle the deficiency state first. Diabetes insipidus, DI.
Okay, DI. So the body can't use ADH effectively. How does that look clinically? What defines it?
Well, DI is mainly characterized by massive polyuria.
Polyuria, meaning?
Just producing huge amounts of urine. We're talking liters and liters a day. The body is just dumping water.
Wow.
And that leads to polydipsia, this intense, constant urge to drink water to try and keep up.
So you drink a lot, you pee a lot.
Exactly. But interestingly, and this can seem a bit counterintuitive, most DI patients are actually euvolemic.
Their total fluid volume is normal.
Yeah, because that powerful thirst mechanism usually compensates pretty well for the losses. The problem is the constant turnover, the flux.
Got it. Now, we need to figure out why the ADH system isn't working. And this is where diagnosis really hinges on distinguishing the types.
That's right. Two main types. First, there's central DI. This is the classic not enough ADH.
The source isn't producing it.
Right. The pituitary system fails to make or secrete enough ADH. So if you measured it in the blood, the serum ADH level would be low.
Okay, that's straightforward deficiency. What's the other main type?
That's nephrogenic DI. Nephro meaning kidney.
So the problem's in the kidney.
Exactly. Here, the ADH might be there, circulating maybe even at high levels, but the kidneys just don't respond. The receptors aren't working right.
Why wouldn't they work?
Could be genetic, like mutations in the AVP receptors themselves, reducing their activity, or problems with the water channels, AQP2. And then there are acquired causes. The classic medication-induced one you always hear about is lithium.
Right. Lithium toxicity.
Yeah, it can really mess with the kidney's response to ADH.
So we have central DI production failure and nephrogenic DI receptor or kidney failure. But you also mentioned primary polydipsia. How does that fit in?
Right. Primary polydipsia, sometimes called psychogenic polydipsia. This isn't a true ADH problem. It's when someone drinks excessive amounts of water for other reasons.
And that suppresses ADH.
Exactly. The constant fluid intake dilutes the blood, lowers osmolality, and tells the brain, hey, we don't need ADH right now. So ADH levels are low and they pee a lot, mimicking DI. This makes diagnosis tricky.
I can see that.
Yeah.
How do clinicians sort this out? Central DI, nephrogenic DI, primary polydipsia, they all involve lots of peeing.
It is a challenge. The key diagnostic tool has traditionally been the water deprivation test, the WDT.
The WDT. Okay, how does that help distinguish them? You basically stop the patient from drinking.
Yeah, carefully, under supervision. You restrict water intake, which should normally cause the body to release ADH and concentrate the urine to conserve water.
Okay.
So you watch the urine osmolality, how concentrated it gets. In central DI, the patient can't concentrate their urine because they don't have the ADH signal.
Makes sense.
But then the crucial step, you give them desmopressin, DDAVP, which is synthetic ADH.
And what happens?
Their urine osmolality shoots right up. Because the kidneys are fine, they just needed the hormone signal. That confirms central DI.
Okay, clear response to the synthetic hormone. What about nephrogenic DI during the test?
In nephrogenic DI, the urine stays dilute during water deprivation because the kidneys aren't responding to the body's own ADH. And critically, when you give them DDAVP,
Nothing happens.
pretty much, the urine osmolality still stays low. It proves the problem is at the kidney level, the receptors aren't working.
And primary polydipsia.
With primary polydipsia, because their ADH system is actually intact, just suppressed, they usually can concentrate their urine somewhat during water deprivation, even before getting DDAVP. It shows their system works, it was just overwhelmed by all the drinking.
That's a neat way to test the mechanism. But I hear the WDT can be lengthy and unpleasant. Are there newer approaches? You mentioned copeptin.
Yes, copeptin is a fantastic development. It's part of the precursor molecule for ADH. When the body makes and releases ADH, it releases copeptin in a 1-to-1 ratio.
Okay.
And ADH itself is actually kind of tricky to measure accurately and quickly in the blood. It degrades fast. But copeptin is stable and easy to measure with an ELISA test.
So it's a reliable stand-in? A surrogate marker for ADH levels?
An incredibly reliable one. So instead of the hours-long WDT, you might just do a blood draw for copeptin.
How does that help differentiate?
Well, think about it. If a patient has polyuria and you measure copeptin and it's high.
That means the body is releasing ADH and copeptin.
Exactly, which immediately points away from central DI. It strongly suggests either nephrogenic DI, ADH is there but not working, or perhaps primary polydipsia, where ADH release might fluctuate. It really helps narrow things down much faster.
That's a big improvement. Okay, let's shift to treatment. Central DI, first, the problem is hormone deficiency. So replacement seems logical.
And that's exactly it. Desmopressin, DDAVP is the main treatment. Synthetic ADH, given usually as a nasal spray or pill.
Straightforward replacement.
Mostly. But interestingly, there are also older drugs sometimes used, things that try to stimulate the pituitary to squeeze out any remaining ADH it might have. Like carbamazepine.
Tegretol, the anti-epileptic.
That's the one. Or chlorpropamide, an older diabetes drug. It's always a bit surprising to see these used for fluid balance.
Shows how interconnected things are. Now, nephrogenic DI, the kidney, isn't listening. You can't just give more DDAVP if the receptors are broken. How on earth do you treat that? Stop constant water loss.
Right. This is where we get to that really interesting kind of perplexing treatment. It's a classic clinical pearl. The surprising approach is to give thiazide diuretics.
Wait, diuretics? Don't they make you lose fluid? You're giving them to someone already losing too much fluid. That sounds completely backwards.
It absolutely does. And honestly, for a long time, textbooks basically just said the mechanism was unknown.
So what's the thinking now?
The leading hypothesis is that the thiazide causes a mild state of salt and water loss, initially mild volume contraction.
Okay.
This then triggers the proximal tubule in the kidney, the part before the ADH-sensitive collecting ducts, to reabsorb more salt and water much earlier in the process.
So you're increasing reabsorption upstream to compensate for the failure downstream.
That seems to be the idea. You sort of bypass the broken part of the system by enhancing an earlier step. They often add an NSAID like indomethacin too, though its exact role in this combination is still a bit murky.
Clever, even if not fully understood. It works, though.
It does reduce the polyuria, yeah. It's effective.
Okay, fascinating stuff. Now we have to pivot completely from not enough ADH to the other extreme, too much ADH. This brings us to SIADH.
Syndrome of inappropriate ADH secretion.
What's the core issue here?
It's uncontrolled, persistent ADH release, and it's inappropriate because the ADH is being released even when it shouldn't be, like when plasma osmolality is already low and the body doesn't need to conserve water.
So, too much ADH signal.
Leads directly to too much water reabsorption by the kidneys. Massive water retention.
And if you hold on to too much water, diluting the body's salt. What's the critical consequence we see?
The absolute hallmark and the cause of most symptoms is hyponatremia, low plasma sodium.
Sodium.
Yeah. The signs and symptoms of SIADH, things like confusion, headache, nausea, in severe cases, seizures or coma, they're primarily driven by that hyponatremia and the resulting brain cell swelling.
And what about their volume status? Are they overloaded with fluid?
Interestingly, just like the DA patients were often euvolemic, SIADH patients are also typically euvolemic or maybe just mildly hypervolemic.
Why aren't they hugely overloaded if they're retaining so much water?
Because the body has some escape mechanisms. When you retain water, you eventually trigger processes that lead to some sodium excretion, trying to normalize things a bit. So they don't usually get massive edema like in heart failure.
Okay, so if a patient comes in, seems euvolemic, but has low serum sodium, what else confirms SIADH diagnostically?
Two key things together: low serum sodium and urine that is inappropriately concentrated.
Meaning the kidneys are still holding onto water, making concentrated urine, even when the blood is dilute.
Precisely. The urine osmolality will be higher than you'd expect given the low plasma osmolality. The kidneys are obeying the inappropriate ADH signal.
This is where getting the diagnosis right is vital, especially regarding volume status. Let's talk about that clinical pearl involving central venous pressure, CVP.
Yes. This is a crucial point, often tested. Remember, SIADH patients are typically euvolemic. They're retaining water, but they aren't truly volume depleted. Therefore, if you measure their CVP and it's low, say less than 5 mmHg, it's actually very inconsistent with SIADH.
Why? What does a low CVP suggest instead?
A low CVP indicates volume depletion. If you have hyponatremia and evidence of volume depletion, like low CVP, you need to strongly consider cerebral salt wasting, CSW.
Cerebral salt wasting. Different problem entirely.
Completely different pathophysiology. In CSW, the brain injury or condition causes the kidneys to actively waste salt, and water follows. So they are losing both salt and volume.
And the treatment would be opposite.
Diametrically opposite. In CSW, they need salt and fluid replacement because they're depleted. In SIADH, the cornerstone of treatment is
fluid restriction.
Exactly, water restriction. Limiting fluid intake is the simplest, most direct way to help the body get rid of the excess free water and allow the sodium concentration to rise. Giving fluids like you would in CSW could be dangerous in SIADH.
That distinction is critical. Okay, so water restriction first for SIADH. What if that's not enough or the hyponatremia is severe and dangerous?
For acute, severe, symptomatic hyponatremia, we might carefully administer hypertonic saline concentrated salt water to raise the sodium level relatively quickly, but you have to be very careful not to correct too fast.
Right, risk of osmotic demyelination.
Exactly. But for more chronic management, especially in patients who are euvolemic, we now have targeted therapies, the Vaptins.
Vaptins. These sound like the pharmacological opposite of DDAVP for central DI.
That's a great way to think about it. Vaptins are AVP receptor antagonists. They block the ADH receptors in the kidney collecting ducts.
So they stop the ADH signal from working.
Precisely. By blocking ADH's effect, they allow the kidneys to excrete free water without losing lots of salt. It's called aquaresis.
Getting rid of just the excess water.
Yes. Drugs like tolvaptan, brand name SAMA-CA, for example, are approved for treating euvolemic and hypervolemic hyponatremia, like you see in SIADH or sometimes heart failure. It's a direct countermeasure to the excess ADH effect.
This has been, wow, a really detailed tour of the body's water regulation system and its extremes. Let's try and synthesize the main points.
I think the core takeaway really is just appreciating AVP-ADH as the single, incredibly potent chemical lever. Its function, or dysfunction, dictates the entire water balance by controlling how easily water passes through the end part of the kidney tubule, and whether you have too little action, like in DI, or too much, like an SIADH.
The results are these dramatic shifts in plasma osmolality and sodium levels.
Absolutely,
Right.
which demands really precise diagnosis. You can't just go by symptoms of thirst or confusion alone. You need to triangulate, look at the ADH level or its proxycopeptin.
Plasma osmolality, urine concentration, volume status.
Exactly, putting all those pieces together.
It really is precision medicine in action.
It is. And what still stands out to me, even after all this time studying it, are the lingering questions. We talked about treating nephrogenic DI with thiazides and NSAIDs.
Right, the counterintuitive approach.
We have a good working hypothesis now about bypassing the problem via proximal reabsorption, but the exact interplay, especially with NSAIDs, isn't fully nailed down. The fact that a standard treatment relies on a mechanism that's effective, that's still partly, inferred, it highlights that there's still mystery here.
It's a good reminder that physiology and pharmacology don't always reveal all their secrets easily.
Not at all.
Hmm.
And maybe a final thought for you to consider listening to this deep dive. Think about the sheer, almost terrifying power packed into a single receptor's function. Imagine a rare condition like nephrogenic SIADH caused by a mutation making the ADH receptor constitutively active, always switched on, no matter what.
So the kidney constantly reabsorbs water,
Yeah.
regardless of ADH levels.
Regardless of anything, one tiny genetic fluke, one protein stuck in the on position, and the body's entire fluid equilibrium is thrown completely out of whack, totally disconnected from actual physiological needs. It just underscores how incredibly finely tuned and perhaps fragile this whole system of homeostasis really is.